My dog. You can't see him, but I just scared him twice.
By clapping?
Yeah, he's very...
Dog's got problems. Needs some Prozac.
He's old. No, he needs Prevagen. He's old.
Don't get me started.
Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is as confused by the latest health study as I am by meteors that may have brought COVID to the world. Did you guys hear about this?
Did you say that the world is confusing?
Meteors. There was a paper that suggests that COVID was brought to the United States, to the world, by meteors.
I missed that paper. Where was that? The Journal of Irreproducible Results?
I'm pretty sure it was. It certainly caused a firestorm of disbelief.
Seriously?
Yeah.
Did you read the original paper?
No, I'm not going to do that.
I would like to.
Anyway, I am Matt Fox from the Departments of Epidemiology and Global Health, and I am here with Chris Gill from the Department of Global Health. Welcome, Chris.
Hi, I only have one department.
That is a good point. And I am also here with Don Thea from the Department of Global Health. Welcome, Don.
Yes, I only have one department, too.
So the two of us equal you.
I don't think you should feel jealous.
Don and I are each one half Fox unit.
That sounds about right. Is that in any way similar to Smoots?
Smoots. No, what's that like? A 5'10" guy who lay down and crossed the bridge multiple times?
That is the story. For anyone who doesn't know, the yes. Smoots are a guy who rolled all the way across the MIT bridge here in Boston, and they measured out the entire bridge in Smoots. Is that what he did? He rolled across?
Or he lay down over and over or something?
Head to toe. Head to toe.
Well, that makes more sense, actually. Anyway, as a reminder, if you could all head over to the Population Health Exchange website at www.pophealthex.org. That's BU's hub for lifelong learning, and you'll find lots of interesting stuff there. And then as another reminder, go ahead and rate us on iTunes or all your other major podcast sites. We haven't gotten a review in a while, and I'm starting to feel neglected. I don't know about you guys.
But we did get a nice email that Nick Guler just read to us.
We did, and we love those. It totally makes our day. Anyway, now on to the show. So today in our first segment, which is our Journal Club segment, we are going to look at a study on vitamin D supplementation on the risk of getting tuberculosis. Then in the second part of the podcast, which is our deep dive, we'll talk about citation hacking and whether or not that is in fact a thing. And then in our third segment, which is our amazing and amusing, we will get into some things that make us laugh out loud or just we found amazing. So let's do segment one. We're going to talk about an article that looked at the impact of vitamin D on prevention of tuberculosis, published in the New England Journal of Medicine, and it was entitled Vitamin D Supplements for Prevention of Tuberculosis Infection and Disease by first author Davasambu Ganma of the Department of Nutrition at the Harvard T.H. Chan School of Public Health. So a couple of headlines on this one. Medscape says vitamin D supplementation in deficient children fails to lower tuberculosis risk, and the 2-Minute Medicine says vitamin D supplementation not associated with lower risk of tuberculosis in school-aged children. So, Chris, can you start us off by telling us what this study was all about and what they found?
Sure. It's just kind of an interesting trial because it's testing a very curious hypothesis that actually has been bouncing around for a long time about the relationship between vitamin D and tuberculosis risk. So vitamin D, pretty much everyone will have heard of. It's a hormone that has all sorts of interesting effects in the body, and one of the main ones is regulating calcium, and it has a role also in bone development. But vitamin D is a steroid hormone, which means it's derived from a cholesterol background with some modification of side chains. And steroid hormones, as a rule, do all sorts of stuff in the body, so that it's rare that you'll find like one effect. And in vitamin D's case, it has apparently some effects related to the function of macrophages in the innate immune system. Deficiency of vitamin D is supposed to lead to sort of a slight immunosuppressant state. But curiously, I've seen arguments recently where vitamin D is considered to be a counter-regulatory hormone for the innate immune system, meaning that it damps down the innate immune system. So it's a curious thing, and I don't know enough about the biology of vitamin D to know whether it might actually be possible that these are both true. But in any case, vitamin D deficiency in epidemiologic studies has been shown to be associated with all sorts of TB metrics, including getting tuberculosis or converting your skin test or having a conversion to a positive quantiferon test, which is considered to be a more specific test than the purified protein derivative skin prick that we're more familiar with. And that vitamin D also might be associated, like low levels of vitamin D might also be, associated with poorer TB outcomes. So, but again, as with all of these things, these are largely based on observational studies. And there's a tremendous opportunity here for confounding, because vitamin D deficiency could be associated with general protein calorie malnutrition and just be another sign of poverty, that you're not getting enough milk in your diet or enough calcium or cheese or high protein foods with vitamin D in them in your diet. And all of those are, clearly things that could explain higher rates of TB. And so the question was ultimately set to a formal experimental test, which is reported in this article, Vitamin D Supplements for Prevention of Tuberculosis Infection and Disease, by first author Ganma. And I should just say that this was the first paper I have seen published in the New England Journal of Medicine that was conducted in Mongolia. So I think that's kind of an interesting feature to this. And the study was all Mongolian children. And the basic hypothesis was, or the structural design was, they randomized kids to get weekly oral mega supplements of vitamin D, by which I mean they received 18,000 international units. To put that in context, when you go to CVS and you get some vitamin D, it's usually about 1,000 microgram or international units per dose. So this would be twice what you would get if you were taking daily vitamin D supplements at home. So it's quite a large dose. But they did this 1 week at a time, and the reason they did it weekly is that they wanted to be able to control and observe whether the kids were actually taking the vitamin D. They wanted to know, I guess, that if the experiment failed, it wasn't because they didn't actually take the experimental drug. And so they did weekly observed administration, either of vitamin D or of a placebo. And this was a placebo-controlled double-blind trial. And then they did that every week for an entire year. And each time for 3 years. And each time that the kids came back, they would ask them, have you had any symptoms? Have you developed any respiratory symptoms in particular? Looking for opportunities to identify incipient tuberculosis. And at the end of the 3-year period, they did another quantiferon test. I should mention, this is very important, in fact, that at the baseline, they excluded kids who already had a positive quantiferon test. So the quantiferon test is a much more sophisticated version of the TB detection screening test that we are familiar with, where you take patients' lymphocytes and you expose them to tuberculosis antigens. And if they have seen them before and have acquired memory to them, they will respond by releasing a lot of gamma interferon cytokine. And if they do that, then you say, aha, this is a person whose immune system has encountered TB, ergo they have been exposed and infected with TB. And so what they wanted to see is how many of the kids in the two groups went from a negative quantiferon test at the start to a positive quantiferon test at the end. That was the basic design. And there were some subtle permutations in there. For one, that they looked at 2 different thresholds for the quantiferon test. The manufacturer recommends 0.35 micrograms as the cutoff for a positive test, but they also looked at 4, so a much higher threshold, reasoning that the 0.35 could be prone to some false positives. So they went for a more specific, but probably is presumably less sensitive result. And they also looked to see if there was a non-specific effect of vitamin D supplementation on respiratory diseases, irrespective of TB specifically. So they ran the study for 3 years, and I have to say that I thought it was quite a rigorously done study. They had, low rates of dropout and loss to follow-up. They had high capture rate. They were able to document that the kids who were supposed to be taking their medicines, that 91% of the medicines that were supposed to have been given were given. And at the end, they also tested their vitamin D levels and found that in the intervention arm, their vitamin D levels were much higher than the ones in the control arm. So they could prove that the vitamin D had gone into these kids' systems. The randomization appeared to be very well balanced. So I feel like in terms of the mechanics of the randomized control trial, they did a great job, which makes the results a little bit more sad in a way, because the vitamin D didn't accomplish anything in any of their endpoints. Straight down the line, there was no effect of the vitamin D, either in terms of interferon, the quantiferon conversion at the 0.35 or the 4 IU per mil levels, or being initiated on treatment for TB, or being diagnosed clinically as having TB. And there was also no impact whatsoever on the frequency of reported or observed diagnosed respiratory infections. And so, in terms of testing the The primary hypothesis, vitamin D showed no evidence whatsoever of having any impact at all on the occurrence of new tuberculosis infections. But an interesting and well-done study, I thought.
Yeah, I share your feeling that this was a pretty well done study. Interestingly enough, one of the things that I wrote down in my notes here was that this kind of felt like the most straightforward study we've read in a long time. It was sort of like basically you go in, you randomize kids into two groups, you give them the vitamin D, you follow them up, and you find out whether or not they got tuberculosis. It's sort of like textbook for how we would describe how to do a randomized trial in class, which I thought was made it very easy to read. Don, what was your take on this study?
Yeah, I agree with both of you guys. I thought it was a very straightforward, very kind of vanilla, but extremely well thought out and well done study to address a question that has been sort of floating around for a while. Just in terms of the mechanics of doing the study, there was one thing that I picked up that I didn't quite understand. And that was in the methods section, when they calculated the size of the cohort that they would need when they're doing their sample size assessment. They did, in the first line of the statistical analysis section, it says, assuming a 2% annual risk of tuberculosis infection. Then in the limitations section, under discussion, they say, our trial had some limitations. A 3.5% incidence of QFT, the quantiferon test that Chris was referring to, conversion as defined by an interferon gamma level at or above the threshold value of 0.35 was lower than the anticipated incidence of 5.9%, which rendered our trial as potentially underpowered. So I don't understand why they used 2% incidence to generate the sample size and then report that the study is underpowered when you consider an incidence of 5.9%.
So I believe
that doesn't make any sense, does it?
No. I think it does. So it's a 2% annual risk of TB, and they ran the trial, I think, over 3 years.
Right. That's right.
So the idea here is that you would expect
I see what you're saying.
roughly a 6%.
Got it.
But
Okay.
Interesting, Don,
Good
that you
pickup.
went to that, because I actually I highlighted that, and I thought you were going to go to a different direction with that, which is they said they assumed a 2% annual risk of tuberculosis. So over 3 years, that gets you to roughly a 5.9 or 6% risk. But they also assumed an 18% risk of loss to follow-up. I mean, can you really do a study of a 2% or, in this case, 6% risk of tuberculosis when you expect 18% loss to follow-up? Now, to be fair to them, the loss to follow-up was lower. It was only about 10%.
Yeah.
But still, that's, almost double the expected rate of tuberculosis. So, that part worries me. Even though 10% is actually pretty low for a trial, it still is problematic when your event rate is low.
I put a circle around that statistic, but for a different reason, which was that I was like, 18% is an awfully specific loss to follow-up rate.
I had the same thought.
Like, why 18%? Why not
possibly?
10, 15, 20, some round on it off? I mean, I know it doesn't matter, but it seems like, like Stephen Colbert would say, it sounds truthy. Yeah. But it also made me wonder whether there was some post hocism going on there that allowed them to back into the 18%. I don't know. But it was a funny number.
That was the other comment that I had, because what they did is they did, in fact, report on a post hoc analysis of there seemed to be some sort of effect maybe in the group of children who had very low vitamin D levels. But I thought it was responsible for them to point that out, but I thought in the discussion they handled it quite well, and they said it really needs to be evaluated with caution, and it might be more hypothesis generating than anything else. But that's an example of, I think where the authors are putting it in the right context.
Yeah, but just sort of to riff on that a little bit, each of the analyses that I summarized earlier on, I just gave the overall response rate between the placebo and the intervention, but they also stratified these based on whether the people in each group were vitamin D deficient at baseline.
Right.
And and that probably matters, because I would assume that vitamin D supplementation wouldn't matter very much unless you were vitamin D deficient to begin with. So it can't necessarily help you unless you have the problem to start with. Mm-hmm. But with almost, with very few exceptions, the vitamin D deficient people didn't show that much effect either. or when they did, there were some big confidence intervals around them. But there were a couple exceptions where it seemed in that unique subset to be possibly effective, you know?
The other thing that struck me in reading through this was how, and you alluded to this, Chris, how there was a bunch of observational data that suggested in certain circumstances, certain aspects of measuring TB illness and prevention and all the rest of that stuff, that there really wasn't there. That vitamin D really did seem to have some sort of effect on tuberculosis. And here we have a phase 3, well-done, double-blind, randomized controlled trial, which shows nothing, in essence, absolutely nothing. And it made it so clear to me that this is the kind of science that we need to be deciding policy on. Not the observational studies done on hydroxychloroquine for COVID or for hyperimmune globulin for COVID. This is such a good example of why really hard, rigorous science is important.
Yeah. In fact, two of those previous randomized controlled trials were done by the same group. The ones that they cite are actually them, right? But so I was curious, like why are we seeing such a striking null result when they're citing such positive preliminary results? Why are they still asking the question, in other words? So I went back and pulled those two papers, and one of the studies was really small. It's like 100 kids, maybe 120 kids, and so it was just totally underpowered to detect anything. And the second one, which showed a positive effect on PPD conversion rather than quantiferon conversion, and also on I think respiratory illness rates, was where the vitamin D supplementation came in the form of milk. So that the intervention group got milk and the control group didn't get milk. But like milk is like super healthy protein slurry. It's good for you in so many ways. And so there's no way to tease out the effect of the vitamin D as opposed to like feeding kids. And I don't think anyone would argue that feeding kids is going to have anything but a positive result on almost any outcome. So,
I think we're generally pro feeding kids for sure. So let me go back for a second because I raised this issue before of, is it possible that the lost follow-up rate, which was about 10%, is contributing to let's just pretend for a moment that there was some small effect of vitamin D supplementation, but because you only had 3.6% of the population developing TB and you had 10% loss to follow-up, maybe that effect gets lost because you just have, loss to follow-up between the arms that biases towards the null. Now, I tried to logic it out in my small brain as to how that actually would play out, and it theoretically seems possible to me, but probably not likely.
So what's your take home, Matt? Is there a rule of thumb that you can sort of flesh out in terms of low event rate and loss to follow-up rates?
Well, no, I mean, so there's no rule of thumb so much as let's just pretend for the moment that the kids who were lost to follow-up just happened to be very likely to have had tuberculosis, and that has something to do with why they were lost to follow-up. And somehow the differences were dramatically different between those who got vitamin D supplementation and those who didn't, then sure, you could have a difference. But given that it was a placebo-controlled trial, it seems to me unlikely that the kids who dropped out with tuberculosis were differential across arms. So now you're talking about just, again, biasing towards no effect. Still, I just find it hard to imagine that there's much going on that we're missing because of the loss to follow-up, but it strikes me as not impossible, I guess, is where I come down on this.
Which sort of underscores the reason why we do blinded studies.
Right.
Yeah, and I think that's right, but I think you can never completely rule out that something is being missed when you have that much loss to follow-up. Because again, even if it's balanced across the arms, it could just be biasing towards no effect. There is, and this was a null finding, so it's possible there is something going on. But again, I have no reason to believe that's what's happening. I'm just saying it throws a little bit of a doubt in my mind.
Yeah.
I just want to mention one other thing, and that is, when you go to PubMed and you bring up a paper, I went to PubMed and brought this paper up, and as I was looking across the page, that little button at the bottom that says, would you like to look at other studies that are very similar? And so I pushed that button, and a whole bunch of randomized controlled trials of vitamin D with different outcomes came up. And I just wanted to list the number of papers in that list that had no results in terms of vitamin D efficacy for a beneficial effect. So it had no effect against gut cancer, no effect against type 2 diabetes, no effect against TB with HIV, no effect with overall mortality in the elderly, with sickle cell disease, with COPD, with critically ill people with respect to mortality, viral URIs in healthy kids, prevention of cancer and heart disease, colorectal adenomas. And in fact, there was one study that found that there was an increased risk of falling in the elderly.
Oh, really?
With supplementation.
Well,
so it sort of brings up the question, did they really expect to see a finding with respect to vitamin D and tuberculosis?
Yeah.
It just seems like there's an overwhelming amount of evidence to suggest that even people who were deficient in these vitamins don't seem to have a generally beneficial effect on these specific diseases.
Yeah, it almost makes you want to go back and do a randomized controlled trial to see if vitamin D actually prevents rickets too.
Yeah, right.
You're starting the evidence is starting to pile up on the vitamin D doesn't do anything side.
Right.
And we looked at fractures a couple of years ago, and
that's right.
And nothing, as I recall.
So why does my doctor keep telling me to take vitamin D?
Why not?
Huh.
And there's a lot of talk about taking vitamin D to
prevent COVID,
to have a better outcome with COVID. Yeah. Because interferon apparently is blocked, particularly in people with vitamin D, and that's a really important factor with respect to COVID.
It might forestall the so-called cytokine storms in some complicated way, and maybe it will. Maybe this will be the exception. But you're right, Don. There aren't a whole lot of successes here in the vitamin D is good for anything other than rickets literature at this point.
But a well-done study.
But a very well-done study.
Okay, so
yet another
let me
thing
go
that
back.
vitamin D does not do is prevent TB.
So let me
Sorry.
Okay, so let me go back to the issue that I think Don raised earlier about the subgroup analysis that they did. So let me just read this to you so that it's in the record. So it says, however, subgroup analysis of quantiferon conversion, so testing positive for tuberculosis, at the threshold of 4 international units per millimeter raised the possibility that children with a baseline vitamin D level below 10 nanograms per milliliter, the risk of quantiferon conversion at this higher cutoff was lower among children assigned to receive vitamin D than those assigned to the placebo, adjusted risk ratio of 0.41, 95% confidence interval from 0.17 to 0.99. Okay, so if I'm getting this right, this would suggest that while there was no overall effect, there is the possibility of an effect in kids with higher or lower baseline levels of vitamin D? Lower.
Yeah, but
so the more vitamin D deficient you are, there's a possibility that this actually does work. Do you buy this?
No. This is almost by definition data dredging. They bombed on everything else, and now we're not in a sub-analysis, but we're in a stratified sub-analysis. And we're talking very low numbers here. So to put it in comparison, when they did their main effects analysis around the 0.35 level, the overall numbers of TB versus cases in the two groups were 147, 134 in the vitamin D and placebo respectively. Now, when we're down into the interferon greater than 4, which is a much higher bar, now we're down to the level of 7 versus 17. So really tiny numbers. And yes, it barely crosses 1 in terms, it fails to cross 1 on the confidence interval. But let's, you would call foul on that a million times over. That at this point, we're just desperate to see something, to justify the next trial.
Okay, and first I was confused, Chris. You're saying it's a subset of a subset because it is subsetted to both those with very low baseline vitamin D levels.
The subset analysis is the interferon gamma levels greater than 4, right? So their primary analysis is the 0.35 level. And so they've chosen 4 based on some paper they read in the literature that said that maybe 4 is better. Fine. But then within that, the overall analysis of the greater than or equal to 4 does not show a significant benefit. And so now they're like, okay, within, greater than 4, within those people who are baseline deficient. So now we're like, that's the second sub-analysis.
Okay, but I don't think that's actually a second sub-analysis. I just think what they did was they changed the definition of conversion for this analysis. But I think that they're only subsetting the data once.
Yeah. Well,
but I take your point.
I think we're down into the world of very small numbers, and we know that when the numbers get small, the event rates, the absolute event rates are so low that like small differences can flip the confidence intervals and go from significant to unsignificant in a heartbeat. And so at this point, I just start saying, like, come on, let's stop pushing this so far.
And I agree with everything you just said there, Chris. Is it enough to be hypothesis generating? In other words, is there enough there that you would say it's worth a study in kids specifically with the very low vitamin D levels using a lower threshold for quantiferon?
Sure. Well, let's be fair. So if I was this group trying to write a grant to the NIH to do a follow-on project to look at this sub-analysis in the with the high-level quantiferon conversions in the patients who are baseline vitamin D deficient, I would have to acknowledge what Don has said before, that there's a string of dozens of failed randomized controlled trials showing that vitamin D doesn't really help. And now this big mega study, which must have cost a lot of money, showing that vitamin D didn't help. I think it would be very hard to justify this over, say, a new COVID study. To me, this feels like the question, that we keep driving nails into the coffin on this one. How many nails do we have to drive before we start to say that the biological plausibility is starting to break down and that this is probably not true? Let's apply some, let's learn from what we've learned here and not just say that any interesting result that pops up in a sub-analysis is somehow going to drive the next trial. At some point we should say is the question not answered already? It doesn't really work.
Bruce, I agree with what you're saying, but I think you are being a little hard on these guys. I think that it's an observation, and I think not including it in the paper would not be right. I think including it is correct, and I thought that they handled it responsibly by saying, however, the results of the subgroup analysis should be interpreted with caution, given that this analysis was performed post hoc, and there was no adjustment for multiple comparisons. They don't mention the very small cell size, but at least they are cautious about it.
Yep. No, I would agree, and I do think overall it was a well-designed trial and certainly provides reasonably convincing evidence. I think that this is not effective, and I think we should probably leave it at that. Though I do want to end by just going back to where Chris started, which is I've never read a New England Journal of Medicine article before with a study conducted in Mongolia, and it got me a bit nostalgic for my Peace Corps days when I was in Turkmenistan, which is not the same as Mongolia, but there are certainly some similarities. And I do wonder how hard it was to do a study in Ulaanbaatar. I also wondered, presumably they did this in Ulaanbaatar because, partly probably because of connections, but because it's a country that is so far north, you would expect low vitamin D levels. Is that right?
Well, they did have a very high baseline rate of low vitamin D. So it seems like vitamin D deficiency is chronic there. Yeah.
Yeah.
Yeah. One of the things about this study being done in Ulaanbaatar that I thought was cool was that in table 1, they got to tell us how many people lived in yurts.
Yep. Which
37% in both groups essentially lived in yurts. And the other item that I thought was a little curious was that they actually listed in table 1 the number of children that were actively smoking.
Oh,
children!
I missed that. What was the number?
So these were 6 to 11-year-olds.
Wow! What percentage was it?
47 overall of the children were actively smoking, and it was 26 in the vitamin D group and 21 in the placebo group.
Okay, so a low number,
like
but that's
still.
But that you would even think to ask that question. Wow!
Right.
This is like Tatum O'Neal in Paper Moon.
That's right.
I don't get that reference, but I will. I will accept
the young
it.
Tatum O'Neal famously smokes at the age of around 8 in this movie.
Yeah. In the movie.
All right. Well, let's move on from there and move on to our second segment, where we're going to talk about an article that was looking at something called citation hacking. It was published was it in Nature or Nature?
Nature Proper.
Nature Proper. So the idea being that, sometimes you find that scientists care a lot about whether or not their work is cited or not. And, there have been cases where scientists have been found to have been working hard to get people to cite their work. So I think we all have been in situations where we have submitted our work for peer review. It comes back and the anonymous peer review comes back and there is a request we should include all of these citations. And you notice that all of them seem to have the same author listed, and you start to wonder whether that is the person who is in fact your peer reviewer. And there certainly have been examples of this happening. And so these authors were interested in looking at whether or not there were ways to study whether citation patterns could be detected to be manipulated in some way. And so they looked for what they referred to as these sort of red flag indicators, such as when researchers frequently receive blocks of consecutive citations in other papers or get disproportionately many citations from one journal. And they certainly claim that they have been able to find examples of this. They do acknowledge, of course, that it is a difficult thing to study and that, it would be hard to say for sure exactly what's going on in each of these different papers. But I thought it was an interesting thing because of this situation that I raised in the beginning, where I find that I am really annoyed when I get back a request to add a whole bunch of citations to my paper that all seem to be coming from one person. So I want to start with just your experiences with this, and then Chris, I'm going to come back to you and ask what you actually thought of this article, because I know you have some strong feelings. But Don, have you been in this situation where you've been pressured to add citations before?
Yeah, not that often, but it has happened. And I guess I've been totally naive to this topic because I never put two and two together. I never thought that those requests were nefarious or self-serving in any way. I just sort of like, well, yeah, the title seems like it's appropriate. It sort of fits in, and I don't really oftentimes question it. So I don't have a real deep experience in this.
Chris, what about you?
I have experienced it on a few occasions, but to my memory, I don't think any of them struck me as egregious. They felt like sensible suggestions. And indeed, when I pulled the papers, they're like, "Oh yeah, this is I should have known about this." And I've been in the opposite situation where you've been asked to review someone's paper, and that's because you're an expert in the topic that they're writing about, and you find that they have not cited a key paper that you wrote that is actually clearly very relevant to the thing that they're talking about. And so I have suggested that they refer to some of my own citations. I don't think I've ever done it as please cite the collected works of the wise C.J. Gill. I haven't gone that far, and so I think there's a spectrum of behavior here, and not all of it is necessarily malfeasance. Some of it is part of the reason why you were selected as a reviewer. But the thing that kind of irritated me about what they were describing here is the implication that you're kind of being blackmailed into it. That because they have your fate in their hands, because these are the reviewers of the journal or sometimes the editors of the journal, who are trying to bully you into citing their papers. And it's not to make your paper better, it's simply to get more citations for them. I think that's kind of where it becomes a little bit sleazy.
So I have to say, I've only ever once asked somebody to add a citation to a paper of my own. And it was, it was one case where I thought, there's a pretty good reason why they wouldn't know about this. It just came out. And so I listed it, but I also was upfront that it was my paper. And I said, it's up to the authors whether or not to include it. So Chris, what did you actually think of the methods?
I guess they cite their own limitation several times, which is that there's no ground truth, right? All they're looking at is sort of skewness from a predicted distribution of behaviors. And so the problem is that you can't really interpret at the end, does this support their thesis that there are some bad actors? Probably, but I don't know. All in all, I found it, I was sort of more puzzled than convinced by the end of it that they'd really found something. And in the few cases that they cited where they'd sort of dug into the details and it seemed very egregious, I was like, yeah, okay, they got that guy, that guy is guilty. But for the rest of it, since they hadn't done that, I was sort of scratching my head and wondering what to make of it, and not entirely persuaded.
So you're not convinced that either this is a particularly big problem or that there was a lot of evidence of it going on here?
That's right. Yeah.
Yeah. It does strike me that this is in my experience, it's something, as I said, I've come across, but I wouldn't say it happens very often. So I would kind of, my prior going into it is I would be surprised if this was a major issue. And, it seems to me like there is the chance for this to be overblown.
Yeah.
Don, what about you?
Yeah, no, what I was going to say was that being on the A&P committee at Boston University,
Promotions committee,
right? The metrics of achievement for promoting a faculty member have changed over time, and it used to be how many papers did you have published and what were the what's the impact factor of the journals, but now because generating these statistics have become so sort of automatic and so accessible, we now have H indexes and we have number of citations. And so I can completely understand how nefarious faculty members with nefarious motivations would see this as an important way to tip the balance in terms of getting promoted. So it's something that is important to consider, because that might be something that people could really twist to their own advantage.
Well, I agree about that, because I was most struck by the implication of this analysis and the focus on it, which is that, like, have we all gone mad? Surely we are like, there are people out there who are way too obsessed with their citation indices. And if they're playing all these games, either like they're crazy to be doing so because this is like taking things to a ridiculous extreme, or that the incentives that have been created in universities are absolutely bonkers and they have no choice. I don't know which one it is, but like either way, the situation seems insane.
So my assumption is that anytime you build a metric that you use to try and monitor for promotion or other benefit to people, there will always be some people who will manipulate that, for sure. And that manipulation might not necessarily always be nefarious. I mean, it could be as simple as just saying, okay, I want to write my studies in such a way that they get picked up for meta-analyses when, the topic is meta-analyzed, or, I want to write something that is very, very broad, so it'll be cited in the introduction of papers or whatever it is. If you are focused on the idea of getting citations, you could probably maximize your work to try and get the most citations. And that isn't necessarily the same as telling people you must cite my work. So I don't know that the problem is necessarily always nefarious so much as it may just be strategic in some cases.
I am curious, like, about the event rates impact here, right? How many times do you have to like get yourself cited before it has any impact on your H index? Like, how big is your crowbar? If you were, like, say, at some journal and you had access to this, and every 500th paper that came past your desk had something vaguely to do with your research where you could play this game, how many times would you have to do that? And how many papers would you have to generate before it had any impact at all? It seems like this is like shooting peas at a train.
I like that analogy. I do think you're right, Chris. I mean, I think there is the potential for certain people to manipulate it quite a bit, but overall, I think it just strikes me as unlikely for the average person. And my end assessment is this is probably not something we need to spend too much time worrying about.
There's a lot more to worry about.
Yeah, COVID-19 worries me a lot.
Yeah, fair enough. Okay, so that's, good news, because normally we come away from these things totally pessimistic and think it's another indication that our academic world is imminently corruptible. And this one, I think, we came away with the idea that it's probably actually not that big of a deal. And let's chalk that up as a win.
Yeah. Still, we're, the crisis, the magnitude of the crisis cannot be underestimated.
The magnitude of which crisis?
The academic process. So things are still terrible, but this paper doesn't make it any worse.
Wow. Thanks for taking my attempt at optimism and just blowing a hole in it. Really appreciate that.
I got this special hammer for smashing your optimism to bits.
I always thought it was Don's job to be the ultimate pessimist.
The naysayer.
Yeah.
Yeah. Well.
All right. Well, shall we move on then to our third segment, which is our amazing and amusing. Don, you want to go first this time?
Yes, I would love to go first. All right. So I have a paper that was published in the International Journal of Cancer in 2003 by Silvano Gallus, Cristina Bossetti, Renato Talmini, and Carlo Lavecchia. All of the authors are from both Naples and Milan, and the importance of where they're from will be borne out when I tell you what this paper is about. So,
and just to be clear, you just said both? They're from both of these places or either of these places?
Either of these places.
Okay, got it.
I think some are from both, but most of them are from either.
Which of the places also, again?
It's Milan, Italy, and Naples.
Naples.
Got it.
Okay, got it.
All right, so they had a case control study that was being conducted in Italy between 1991 and 2000, where they listed cancer rates, cancer of the oral cavity and the pharynx, the esophagus, the larynx, the colon, and the rectum, with controls of about 5,000 individuals versus the 598 cases of patients admitted for acute neoplastic conditions to the same hospital network as the case non-neoplastic conditions. So it's cancer and not cancer of these various sorts. And so what they did was they, in this case control study, they administered a questionnaire which contained a whole lot of demographic information, but it also contained a validated 78-item food frequency questionnaire that included specific questions on pizza.
Oh, well, that makes sense.
Pizza consumption. So for the present analyses, they essentially looked at the responses to the pizza questions, which were pizza eating was classified in three categories. Non-eaters, which is less than one portion of pizza per month. Occasional eaters, which is 1 to 3 portions per month. And then regular eaters, which was 1 portion of pizza or more per week, which in my book is not a regular. That's a rare pizza eater.
Yeah, I was going to say.
That's a very... I've eaten pizza 3 times this week alone.
Right. This is the definition of pizzapedia.
So for you guys, this will be extremely good news. So they found that the odds ratio for regular pizza consumers were the following. For oral and pharyngeal cancer, the odds ratio was 0.66.
Wow. Excellent news.
For esophageal cancer, it was 0.82. For laryngeal cancer, it was 0.74. Colon cancer, 0.93. And for rectal cancer, 0.68.
So protective, in all cases protective.
In every single case, it was protective.
Well, I just want to say that, like, we talked about observational studies and how, like, the whole thing skews you towards thinking that vitamin D cures everything. And that's all true for that literature. But in this case, I'm sure it's correct.
It's 100% correct. There's no,
and I don't
no
think
doubt
we need
about
any
it.
randomized controlled trials because it's so obvious to be. And beer probably helps too.
So then the authors try to justify it. They say the favorable influence on the risk of neoplasms investigated may therefore be related to tomatoes or olive oil, which have been shown to be inversely associated with the risk of various cancers, including those of the digestive tract. Cooked tomatoes, and especially tomato sauce, are rich in lycopene, a carotenoid that has been shown inversely related to cancer of the prostate in the U.S. They go on to continue to justify it. I thought this was the best piece of creative writing I have seen in a long time.
I would like to see this study further stratified by the pizza topping.
By pepperoni?
I would like to know that pepperoni is in fact protective.
I bet eggplant has to be.
Well, I think anchovies, of course, because they're filled with omega-3 fatty acids.
There you go.
No, pepperoni. It's pepperoni or nothing.
Wow, this is great news. Thanks, Don.
Great news, isn't it? Made my day.
Yeah, I believe it.
Made my week.
With all my heart.
All right, Chris, what do you got for us?
Well, it's not really an amazing and amusing per se, but I was listening to another podcast, which I really like, TWIV, This Week in Virology.
Oh, yeah, that's a great podcast.
That is
a great podcast.
And they were interviewing Michael Mina about, and he was talking about his argument for why
such a good argument.
You need to test frequently against COVID-19, and why paradoxically our reliance on a very sensitive but technically sophisticated PCR can kind of get you into trouble. And it was such an elegant argument that I'm going to repeat it here, but I just wanted to apologize to Professor Mina that I may botch it, but it is not for a sincere lack of appreciation for his work and for trying my best.
And this is actually getting a lot of traction, Chris. It's really, it's really, it's been in the Times, in the Post. It's been in a lot of places. And even Giraud, who's the head of the COVID testing effort, has recognized it and is looking into it.
Okay. Well, let me try to sort of summarize the crux of the argument. And I'm going to use a metaphor that Michael Mina did not use. So here's my individual contribution. So the whole thing comes down to the kinetics of viral load over time. And I'm going to, the metaphor is the rocket ship and the parachute. So like, when a rocket ship takes off, it's sitting there on the ramp, and all this smoke is coming out and fire and stuff, but the rocket's not really moving very much until it finally groans into motion and starts to rise. And then it rises very quickly, and then it rises really quickly and goes, whoosh, and off it goes, and so it's going thousands of miles an hour before you say boo. Okay, so that is a little bit akin to like logarithmic growth of a virus over time, where you get exposed at time 0, shall we say, and then if you measure the virus in that person's throat over time, you would probably not detect anything for several days, but then because of the weird kinetics of exponential growth, the virus will suddenly seem to take off and go whoosh, and go from like undetectable to millions of copies per mil of saliva in a very short period of time, like within a day. Woof, off it goes. But then when it sort of peaks and the immune system taps in, this is where the metaphor of the parachute comes in, where the parachutes deploy and the rocket drifts slowly back to the ground. And so the front end of this curve is sort of flat and then whoosh, super steep, like a rocket ship. And then the back end of this curve is slow and ponderous as the rocket ship, in this case COVID-19 levels, slowly come back down to Earth. And that drift down process can last a couple of weeks, where the takeoff process probably takes about a day. Now, his point is that PCR is super sensitive. And if we're testing
PCR being the test that we normally use,
right, the gold standard, right? For example, the Broad Institute's PCR test, they claim, can get you down to 60 viral copies per mil of saliva, which is a very, 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 very low concentration. So it's wicked. It's very, very sensitive test. But the thing is that in infectious diseases and in COVID-19 and all infectious diseases, the dose of the inoculum that you're exposed to matters a lot. Right? So we don't live in a binary world where if you're exposed to any COVID-19, you're going to get infected. You need to have enough COVID-19 that it's going to get its way through your innate immune defenses, which are saturable. So they have a certain limit on their ability to block, certain inoculums. But even so, you need quite a lot of virus. And Mina is saying in his argument that you probably need 100,000 copies per mil, or maybe 1 million or more copies per mil, before you get to the point where you're really contagious to other people, right? So you need a lot of virus. You need to be shedding a lot of virus. And we know that at the peak of viral transmission is actually a couple days before you show symptoms. That's when people are most infectious, and then it comes down. Now, if you're testing, like the staff are doing here at BU, and we're doing it once a week, the probability that your test is going to happen to land on that one day when you hit the peak is around 1 in 7, right? But those other 6 days, you're more likely to, you might catch it in the first couple of days, but it's probable that you're going to catch it on the drift down when the virus is detectable by PCR because it's so good, but that you've already fallen below the level of infectiousness. So what, right? That's the problem, is that the infrequent PCR testing is almost by definition going to find lots of virus in people who are no longer contagious, and yet we're going to quarantine them. And so the quarantining part of this is not very efficient. On the other hand, you can still use those data to do contact tracing, and so you can do secondary containment. So it's not useless, at all useless, but it is limited, because what you would really like to do is to be able to capture them just at the point where they became contagious and quarantine them then. That's the most useful time. But you can't easily do that if you're testing once every 7 to 10 days. It's just not, statistically it's not possible. And so what he's saying is that instead, because PCR is expensive and fussy and takes, a day or two to turn around, or in the cases of, many parts of the country, 2 weeks, it turns out, to turn around a result. Instead of that, what if we used a worse test, like an antibody capture assay on a piece of cellulose, basically something that acted like a pregnancy test, where you could suck on a swab and then you'd have a result at home, so you could do this yourself in about 15 minutes. So, you can kind of imagine the model where you get up, you brush your teeth, you spit a lot, or maybe you do it the other way around. You get up and you do your COVID test, and then you brush your teeth for 15 minutes while you wait for the results. And so the dentist is happy too. And now you have your answer. Am I okay to go to work today? Because your COVID test is positive or negative. Now, those tests are much less sensitive than the PCR, right? Which means that they're going to be able to detect a much higher concentration of a virus before you get to the point where the test can no longer pick it up. But that's okay, because the stuff that the PCR is picking up is also irrelevant. It's too low to be contagious. And so what you're missing is the drift down period. So you don't see the far right of the tail. But from the purposes of isolating someone who's now contagious, the antigen tests are perfectly able to capture someone as they hit the peak, right? Because the concentration of virus is so high. And that's the one you care about. And so if you could do that every day at home for $1 a day per person, you would now actually have a much better way of mapping the epidemic and coordinating your containment efforts, starting with, oh my gosh, I'm infected, I am contagious, I should not go to work, I should stay away from my family, and I need to call someone to help me, do the contact tracing. And so basically his argument is that it's not that he's saying a worse test is better than PCR. He's not saying that at all. What he's saying is that a worse test that could be done daily is better than a better test that could only be done weekly. And that actually that it's the frequency of the test that is the benefit. The more frequently you can do it, the more valuable the test becomes. And that frequency, the benefit of the frequency, overwhelms the loss in sensitivity. And I thought it was such an interesting argument and so almost certainly true.
I totally agree with you, Chris. I thought this was fascinating. I heard him on it got so much interest. I heard him on the Political Gab Fest that Slate does. And I'm so with you on this one. I think it's a really interesting take.
Yeah, I think the other two things about his argument is that these PCR tests that don't come back for 10 days are thoroughly useless in terms of population control.
What are you going to do?
The other thing is that tail that you're talking about, Chris, can last for weeks.
That's right.
But nobody's been able to really show with any degree of volume that those positive PCR tests beyond 12 to 14 days after the onset of symptoms are in fact infectious. Those are shards of RNA. They're not whole infectious viruses. It's sort of underscoring the argument even more.
Right.
Because a lot of the positive tests that come back are not reflective of infectiousness.
So in a way, the sensitivity of the PCR is also having the effect of driving us all a little bit crazy because it keeps detecting stuff that doesn't matter.
Yeah. So cool. So cool. All right. Well, I will go last. I got a short one, but I do have a question for you guys.
Oh.
Why do we have eyes?
All the better to see you with, my love.
See, I always assumed that was the only reason we had eyes, was to see. But apparently, another reason that we have eyes is to as an anti-predator signal. So that the predator sees that you see the predator, and then the predator doesn't attack, and it waits until you turn around to attack. And you could see this with like fish that develop eye-looking things on their sides that sort of increase their ability to protect themselves. So there was this group. This was published in Communications Biology by Cameron Radford and colleagues, in which they asked the question. So they were working with cattle in Botswana, where people are worried about lions and leopards taking out their cattle. And so they asked the question, does painting eye spots on the backsides of cows increase their survival? And so, because they're cows, you can do a very nice, large, randomized trial, which they did. And they randomized to one of three groups. So they either got nothing painted on them, they got cross marks painted on them, on their backsides, or they got eye spots painted on their backsides. And they found a statistically significant reduction in the number of cattle that were killed over 25 days if they had the eye spots painted on them compared to having no markings on them. Yeah.
That is awesome.
Now, that said, I do have a little quibble with this study, is they did do a Kaplan-Meier curve of their results.
Oh.
And there were no cattle with the eye spots on them that were killed, but the percent that were killed in the eye spot group and in the crossmark group and the unmarked group was less than 2% in both cases. So a little hard to draw very strong conclusions here. But still, I thought it was a pretty clever idea and a very, something that you could easily test when you're dealing with, creatures that don't require informed consent, I guess.
Yeah.
And large numbers are easy to do.
I found a similar article to this because I'm a big fan of Calvin and Hobbes, and there's a segment where Calvin wears a back-facing mask to persuade Hobbes not to attack him. It doesn't work. Mm-hmm. But so I just Googled back-facing masks and tigers, and there's an article in the New York Times from 1989 where they did this experiment in humans in the Ganges Delta in India, where people were living in a tiger preserve, and the people were getting eaten at the rate of about 60 people a year by the tigers. And so they deployed 2,500 tiger masks to a bunch of people. And in the next year or so, 3 years, they say, and there's a quote, "For the past 3 years, no one wearing a mask has been killed." And they cited tigers have been seen following people wearing the mask, but they have not attacked. But in contrast, 29 people were eaten while not wearing masks. So they felt that this was a winner.
Huh.
So I think
I'm
there's 2 data points here.
I think it's the way to go now. I think we should all be wearing tiger masks and eyes painted on the back of our heads.
I'm going to wear a tiger mask while I'm eating my pizza.
I think that's a really smart idea. You'll live forever. Well, that is the end of our program. If you got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at @PopHealthEX, or you can tweet me at @ProfMadFox, or Chris at id.gill, or Don at @dtheo1, or you can find us on the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Delalian, Director of Lifelong Learning at BU School of Public Health, for supporting the podcast, and Nick Guler for sound, editing, and being the best at finding a new barber.
By golly, thank you, Nick and Leslie.
Thank you both. So thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode.